Hello, welcome everyone. We may be joined by some other people over the next few minutes, but let's get started. Just on some practicalities, this is being recorded already. You should have received a notification when you came in, which means you can choose whether or not to have your video on, but I think we're suggesting people don't while I talk. But the idea is this should be a slightly smaller event, so we're hoping there'll be more opportunities for when I finish talking for people to make contributions. So when you do that, what I'll ask people to do is put their hand up, and then I'll go to people and you can ask your question or make your comment about what I'm talking about. So today's event is rather embarrassingly called a masterclass, and I don't think whatever a masterclass is, I don't know if this really is a masterclass, but we wanted to differentiate it from things we do through the Exchange network in particular, which are more practice focused. So there is some practice stuff in here, but I think there's also, and there's quite a bit about research methods, though none of it at a deep level. I guess it's the putting them together. So what I really want to argue is that a lot of the way we've researched what works in children's social care hasn't been particularly helpful, and that looking at reducing care is a good way of understanding some of the reasons for that. And I want to make some proposals for how we could do things, I think, in a much better, more helpful way, which has implications for the research we do, but it also has implications for how we organize research. And I wanted to unpack those and really have a discussion. And what I'm really pleased about is I think we have a mixture of people from various practice settings and researchers, particularly from CASCADE, and that's kind of those are the groups I'm hopeful that we'll talk. We'll be able to talk through some of the issues about how we could create research that really is helpful, because I suppose one of my fundamental feelings is too little of our research is helpful enough. Really, I'm going to give a very biased and partial summary of stuff that I've learned from doing research on this issue for 20-odd years. I'm going to argue that researchers aren't doing the right research, or too often are not doing the right research. And a lot of that is about problems with the methodologies we use. But I'm also going to argue that sector leaders are not evaluating what they're doing in systematic or strong ways. And as a result, the whole thing is not joined up properly, and we don't know enough helpful stuff. And my conclusion is that we need a particular way of working more closely between the sector leaders, practitioners, and researchers in doing different types of research. Well, some types of research we currently do, and some types we don't. I asked Jonathan Scowfield to kindly look over my presentation, and he said there are far too many slides yesterday. So I looked very carefully at it and managed to get rid of one. So I'm going to use my usual solution of going at relatively high speed through quite a lot of slides. If there's anything you're not sure about, you want to ask a question about, if you stick your hand up, I will probably keep going to the end, but we can come back to any points that I sort of skimmed over. I'm going to use care rates as a starting point, because really it helps illustrate a lot of the key problems in this area. I'm not going to belabor some of these statistics, but just to point out that, because many of you will be aware of them, I imagine most of you are aware of them one way or another. But since 1994, the rate of children in care in England has increased by 58%. In Wales, it's much more marked. It's about 150%. So there are 2.5 times more children in care now than there were. There are 2.5 times the number of children in care now than there were in 1994. About 1% of all children in care in Wales are in care, which is one of the highest rates of care in the world. It's higher than I've been able to find for any comparative countries. It varies a lot between local authorities. You're 5 times more likely to be in care in Torfaen compared to Carmarthenshire. And there's questions of equity, fairness. Are all families, all children getting the same service? Effectiveness is the best way of delivering services, and cost effectiveness. Care may be needed for some children, and I'm certainly not against care. I mean, it definitely is needed at times, but is it always the best use of the resources we have? While reducing care, I think, is generally important, it's also quite a complicated measure. It's what we call the Goldilocks measure. So nobody would say you shouldn't have any kids in care, or that all children should be in care. It's one of these things where not too many, not too few, just the right number. That said, there's quite a lot of what you would call contextual evidence that it's high, and that's because historically it's much higher. It seems to be getting higher quite quickly, and it's higher than sort of other countries. And also this general agreement that families should be offered the best chance to stay together if they can. And I guess there's a question about whether we're doing that if we have very high care rates. But one of the reasons I wanted to talk about it, is it's really important from a policy and practice point of view. But a second is that from a research point of view, it's a relative open goal because it's a clearer and easier thing to measure than most things. And I guess this presentation is about, if it is an open goal, why we as a sector have not scored and how we might improve our metaphoric goal scoring. And by metaphoric goal scoring, what I mean is do research that's really going to help the sector. I think we're going to circulate the slides after the session, and I put the references, but just very quickly to give you a sense of the research, I'm going to be sort of summarizing things I learned. There were 2 evaluations of a service called Option 2, which was an intensive family preservation service based in Cardiff and Vale of Glamorgan. The positive findings from that contributed to the creation of intensive family support teams across Wales. We also did a review of the literature on outcomes for children. More recently, we've done scoping review of the international literature on what works in reducing care, and then systematic reviews where you get all the evidence and really try to summarize whether something works or not in relation to signs of safety, family group conferences, and intensive family support services. I've also done a couple of evaluations of whole system changes, including the family safeguarding model in Hertfordshire and reclaiming social work twice, once in Hackney and once it's rolled out across 5 local authorities. I'm just going through that quickly because I'm not really going to talk very much about any of these studies, but just draw out more general lessons. But I am happy to I will in passing say things that may prompt you to ask questions. So if you're particularly interested in signs of safety or family safeguarding Hertfordshire, I'm very happy to open that discussion up later on. Problems with the research evidence is there's very little good research evidence on what works to reduce care rates or the likelihood of children going into care. And I would argue, for reasons I will go through in this presentation, a lot of what exists is not actually that useful for those who lead services. So there's not much evidence, and what there is not very helpful. At which point some of you, I may notice the numbers going down because you were hoping I would say something useful. I hope I will say something useful about what we can do about it. So I'm going to talk about why this is the case, and then I'm going to talk about what I think we could do about it in Wales to create a more useful evidence base that could actually help children and families. So why are there these obvious problems with the research evidence base? One is there's just not enough. There aren't enough studies, very few in the UK, even fewer that would provide evidence about impact. So we tend to be much better at describing and understanding problems than we are at the more difficult task of evaluating what you would do about them. The studies tend to be focused on very specific interventions, EBIs or evidence-based interventions. There's definitely a place for that, and I will talk quite a bit about that, but they're not necessarily a good fit for this problem, because I don't think you could argue that the reason the number of children in care has gone up is because of a lack of specific interventions. There's obviously a broader systemic things going on. And as I'll talk about, the way we do research favours more tightly specified interventions. A third problem is that some very widely used approaches have poor or no evidence base in relation to reducing care. So signs of safety or family group conferences that are extensively used. There's not much evidence that they reduce care, or indeed for those two that they do other things they're meant to do. That doesn't actually mean they don't work. And I'll talk about this quite a lot further on, but I think it probably means that they sometimes work and they sometimes don't, and that therefore the key thing may not be family group conferences, it may be how you do your family group conferences in all sorts of ways. But it also illustrates an issue of how, so given there isn't much evidence, how are leaders making decisions about what they do or don't do? On what basis are they deciding to invest resources in these things? And then crucially, I think this is possibly the biggest issue, is there's not enough identifying and sharing robust evidence when one local authority does something good. So I think there's lots of good stuff out there. And when I talk to people in local authorities, I'm constantly hearing about new and innovative and interesting ways of doing things. But we're not very good at checking out what difference they're making. And then when the ones that work and make a difference, really sharing that fairly quickly and continuing to check whether it works in different places. So I want to unpack what we could do about that. So why do these problems exist? Until recently, there was massive underfunding of social work research generally, and in particular research about what works. So from 15 years ago, there was a calculation that it's about 0.31% of the spend on social care. I couldn't find the figure, but it's something like each person at that time in the National Health Service each year had £1,600 spent on research or evaluation for each person who worked in the NHS, whereas for each person who worked in social care, it was 24 quid. It's a pretty big disparity. We haven't, until recently, we haven't really invested enough in finding out what works, but I think that has changed, or is in the process of changing right now. So the What Works Centre for Children's Social Care in England, the Healthcare Research Wales funding for CASCADE, which is really the first infrastructure funding we've had for a long time. And I think there's equivalent things in Scotland with Celsius and other centres, so there's the Scottish Government funding for research and dissemination. A second issue is that social work researchers have rarely done evaluative work. We've tended to be more interested in understanding, theorising, qualitative work, which is important, but very little focus on what makes a difference, what works, even though when you are social workers, or when researchers are social workers, what they want, that is the #1 thing they want. But again, I think that's beginning to change. I think we're now beginning to get, partly because of the funding, more people interested in evaluative work within social work. But I think the crucial thing, the focus of this talk, is the way we do evaluative research has not produced enough helpful evidence. And I want to unpack why that is, and then look at what we could do about it, which is about the way we fund and think about research. So to do that, I need to explain a bit about research methods, which is also one of the purposes of this, is to begin to look at methodological issues. I'm going to use intensive family preservation services as an example. You don't need to know huge details about this, but just to give you a flavour of it, IFPS is our crisis, were developed to keep kids at home. The idea was kids often come into care in a crisis situation. A crisis is also an opportunity for change. And if we work intensively in a short-term period, we can keep some of those kids at home. In America, it's mostly known as home builders, but there's now lots of variations. Option 2 was an IFPS service delivered in Wales, focused on parents who misuse drugs or alcohol. And partly following my evaluation, but I think more generally, there was a sense that it was a good way of working, and it was rolled out as a model, or part of a model, for intensive family support teams, which are used, I think, across Wales, sometimes within a local authority, sometimes within a collaboration of local authorities. I want to look at different studies and the contributions they've made to help us, A, think about research methods for finding out what works, and B, realizing some of the limitations of every method that we've used to date and what we might begin to think about doing differently. So the challenge for all evaluative research is really to find out that A causes B, that a service causes an outcome. So in terms of intensive family preservation services, IFPS, the question is, do intensive family preservation services keep children in families and keep them out of care? That's the key thing we're looking at. I'm going to look at several methods that have been attempted to understand that. The simplest evaluative method is a before and after study, which is you measure your outcomes before you have the intervention, then you measure them out afterwards, and if they've changed, you can you assume that the service is working. So early IFPS studies found 89 to 100% of children did not enter care. So it works, and millions and millions of pounds were then spent on the approach, the home builders approach. But it ain't necessarily so. because crucially, you cannot know what would have happened without the intervention. Maybe things would have got better anyway. Maybe those kids wouldn't have come into care anyway. And also a key one, I think, for social work is maybe not changing is actually a good outcome. So we often borrow from sort of psychological therapy, the idea that you have to help people overcome their problems, and often that is what we're doing. But sometimes you're just helping a family not get worse. So you're keeping the kids in a family bumping along, and maybe we just want to measure that. The problem here is we can't pick up if things have not got worse, and we can't pick up what would have happened without the service. So a better way of approaching it is to have some sort of comparison. And that's where a comparative, or sometimes a quasi-experimental study, which is where you compare people who receive the service with similar people. And I'll give an example of that because my studies of option 2 are quasi-experimental. Comparisons could be historical. It could be people who previously had similar problems. It could be in another local authority. There's various ways of doing comparisons. But the problem is always that whatever the comparison group, they're likely to have differences to the main group. So it's usually better than not having a comparison group, but how good it is depends how confident you can be that your comparison group is broadly equivalent, and that varies enormously. So both my studies of option 2 were quasi-experimental. We used the fact that it was a crisis intervention service, so it didn't have a waiting list. So they always took detail, or what I was told was, they always took details of referrals, but if they were full, they didn't get a service. So we looked at what happened to those ones who because the service was full, they didn't get a service. But there's immediately, well, there's a couple of problems with this. Firstly, some of them then got re-referred back to the service, and we had to exclude them. And as soon as you do that, your comparison groups may not be valid. But a more important one was in one of the sites we looked at, the comparison group just looked really different from the group that got problems. Basically, they seemed to have much more severe problems. And to be very small, very few. And essentially what we did is we tried to we talked to the people who delivered the service, and what we discovered is they were in the same room or the same office as the people who would make the referrals. And so unlike in the main project, where people would have to phone in a referral, they would just say, "Are you busy? Have you got a space?" And that meant the comparison group wasn't valid. The main one probably was, but we were never able to be completely confident that there wasn't a bit of that going on in the main one as well. So immediately you're saying, well, we did find better outcomes. There were fewer kids in care, and in particular, they were more likely to return home after they'd been in care. And it, achieved statistical significance. But with a comparative study that isn't like this, a quasi-experimental one, the key question is, it's good to have a comparison, but what are the other differences between these two groups? So if you're looking at, let's say you've got a service for children who are sexually exploited in Newport and you want to compare it to one in Cardiff, that's fine. But Cardiff's different in all sorts of other ways as well. So it becomes, difficult to draw conclusions. Not impossible. In fact, I think probably quasi-experimental studies in various ways are the most important part of our, or one of the most important elements of the response we should have, but they're also limited. But if you want to have really equivalent groups, the best thing to do is to randomize people into the two groups. So you randomly select people, some get the intervention, others don't. And the great thing about randomization is if there's a difference in the desired outcomes at the end, because you've randomly allocated people, so if it's a large enough group, they will be equivalent, you can be pretty confident that the difference is because of whatever you did. And the crucial point about this is the groups will be equivalent for things you can measure. So let's say age and gender and ethnicity and whatever. But there will also be equivalent for things you can't measure. And things you can't measure are things like level of motivation, level of enthusiasm to do something. We're now hopefully more familiar with trials than we were before, because obviously vaccine trials have been in the news all the time. And when we want something really robustly tested, an RCT is the toughest test of whether something makes a difference. So RCTs have huge advantages. They allow us to establish causality in a complex world. So the reason RCTs are a fantastic breakthrough for human beings, I mean, they've allowed much of modern medicine and also many other things to be developed, is because in a complex world where all sorts of things can affect stuff, outcomes, they take away all that other stuff and say the only difference between these two groups is the vaccine or the intensive family preservation service that they received. And therefore, if more went into care or fewer went into care, we can be fairly confident it is the thing we delivered. And systematic reviews tend to search for all the, certainly RCTs or quasi-experimental studies, and they tend not to look at before and after studies by and large because they're considered not powerful enough. If you've got any questions about anything I'm asking, do store them up and ask at the end. So looking at RCTs and intensive family preservation services, I mentioned earlier the before and after studies found 80, 90, 100% of kids who were referred to the intensive family preservation services did not go into care, and people were therefore fairly confident this works. They then did a large randomized controlled trial where kids' families were referred to the service, and then they were randomly either allocated intensive family preservation service or not. They got service as usual. And I mean, it was very large. It was something like 1,000, so 1,500 kids, very large numbers. That large RCT found no difference. It found no difference in likelihood of entering care or in any welfare outcome measure of any sort. So no difference in likelihood of entering care was because the kids in about 80% of the kids in both groups didn't go into care. So there's a key issue of whether social workers are genuinely referring kids who are really at risk of entering care or not. But there was also crucial issues about when you drilled down into the RCT, you found in different places it was being done in different ways. So sites varied hugely. Some were having waiting lists, which you can't really do for a crisis intervention service. Some were having large case allocations. You really meant to have one family you work with in the model properly done. And there's this issue of whether they were really focusing on the kids who were at high risk. So at this point, you may be concluding, oh, maybe intensive family preservation services don't work. There were lots more studies. And then we did a systematic review of all those studies, which found overall there was fairly strong evidence that mostly intensive family preservation services were good at keeping kids out of care. How to interpret this? I think this pattern of results illustrates both the contribution and the limits of RCTs. So firstly, an RCT was the toughest test of a service. It really does test whether it makes a difference. But you often find that different RCTs of the same intervention will produce different results, or if you drill down into one big study that in different areas or with different therapists, you're getting very different findings. So a key issue here is what is called implementation fidelity. To what degree is the thing being delivered to a high standard? Understanding this has been a really, really very big challenge for evidence-based practice. Couple of examples here. One is the option 2 service, which I evaluated. I thought had an incredible manager, Rhoda Emlyn-Jones. Many of you may have come across her. A really brilliant team who were very strict about doing the model to a very, very high standard, very high quality. And it produced positive outcomes. I'm fairly confident were working. They're probably not as well as the team thought because we did a longer term follow-up and sometimes kids did come back into care, etc. How is the rollout of intensive family service teams doing? I don't know, and I don't think anyone really knows. But anecdotally, I've heard there's a lot of variation between teams. And I think it's fair to say, to what degree are these still intensive family preservation services? And more importantly, which ones are working and how much? Because my guess is you will be finding some are working really well and some working less well. Picture on the right is the set of Star Wars with the actors and the lights and everything going on, and then afterwards. And I've been struck a couple of times talking to people who've been in RCTs that when it was happening, it was all singing or dancing. So the United Kingdom alcohol treatment trial, the UCAT trial, found positive effects of motivational interviewing and other approaches. When people stop delivering the RCT, very often practitioners stop doing the practice. So there's something there about the process of studying and the quality of what's being delivered and whether we can maintain that process, maintain that quality somehow. So having explained, I think, the problems related to research methods and implementation fidelity, etc., I want to move to what we could do about it and spend the last sort of 10, 15 minutes of my bit of the talk thinking about that. I think we're in this position because we have two very different silos across children's social care. So we have practice, and the picture there is the swampy lowlands where everything's very complicated and difficult to work out. I'm going to summarize my view of the practice situation, which is that in general, research is found to be of limited practical use. Local authorities really do not fund very much research, far less than in health and other settings. When they do, it tends to be too little too late. So my experience is quite often it's to show, because you want us to show a project that you think works, often for other funding purposes. And I think this hampers sector learning and innovation. On the right, we have us academics in our ivory towers. And evaluative research has a strong focus on rigor. So for eligibility and funding, you need to do really strong studies. So things like randomized controlled trials, you're probably more likely to get funding for. This process is incredibly slow and very expensive. So if I develop a bid now, start developing a bid now, I'll be lucky to hear in a year whether or not it gets funded. Roughly 90% of bids do not get funded. And then I'll do a study for a year or two, and you might hear the findings 3 or 4, maybe 5 years down the line. That is far too slow and cumbersome to be really useful for practice by and large. And I think often in the research world, we see the lack of use of research as largely a practice problem, though there's quite a lot of efforts to sort of produce summaries and get research out there. But the idea is we're doing good research, we just need to get it out there. I think it's more complicated than that. I want to suggest we could do better, that we need to be thinking about practice and research should be coming together to create learning organizations. There's various definitions of learning organization, but I still like Garvin's best because it's the simplest, I think. A learning organization is an organization skilled at creating, acquiring, and transferring knowledge and at modifying its behavior, crucially, to reflect new knowledge and insights. So thinking about what I'm proposing, the idea is the essential elements, the core process is trying out new things, finding out if they work, acting on that knowledge. But we also have a bigger secondary process, which is across the sector. We need to be finding out what works in other places, sharing that information, acting on what works elsewhere, but testing whether it works here. Because my point about the implementation stuff is just saying that science and safety works somewhere or family group conferences work in Leeds does not mean that if you set up a family group conference or intensive family preservation service in Llandudno, it will necessarily work. So we need to be constantly testing whether things work, not just one-off, off-the-shelf, big expensive study shows it works, but constant process of discovering whether things work and sharing that. And we're sharing the findings across the sector. Now, we have a big problem here, which is that we're not resourced to do this, but I want to suggest that we should be and make some suggestions about how we might move forward with that and what it might involve. So there's 2 parts now left, maybe another 10 minutes or so. A bit on the types of methods we will be doing, and then a bit on how we might proceed to think about launching a program of work that tried to use these methods. So how would we build our knowledge of what works in Wales? I think we should pilot new services better. Specialist services, certainly, things like IFPS, or any particular services, great. That sounds like a great service that's being developed in Newport, and I think there was one in Bridgend working with pregnant women and their families. But also different ways of doing things within our systems. So it doesn't have to be a specialist service that you refer to. Do we have a new way of doing supervision? Do we want to try to do case conferences in a different way, or reviews of children who are looked after? I think researchers could help develop logic models so there's clarity about what you're doing, what you're trying to achieve. That would help us be clearer about what high quality delivery looks like. So I think some of the work that we've done that has been most useful is not just finding out whether stuff works, but finding out for things like family group conferences. We did a really, Lorna Stabler led on a really good piece of work that tried to describe what good family group conferences are like. And it turns out they're really complicated. There's a lot you have to do before the conference. There's some things in the conference. Crucially, you then need to be following up in certain ways. So simply commissioning an FGC service is not enough. You need to have a real clarity about what a good service looks like. And then we need to be establishing what a difference seems to, establishing whether it seems to make a difference. Now, I think we could be doing all of that much, much better to capture and encourage the creativity and innovation that's going on in the sector, to find the things that are promising, and then, stage 2, start to do comparative studies of promising interventions. I think RCTs could often be much easier than we think. But we could certainly discuss this, because sometimes you need to do a big, bad, big RCT to be sure. But for instance, in relation to reducing the need for care, because we've got a relatively straightforward outcome measure, I think that's easier than some things. But if we can't do an RCT, if we had a larger scale program of work focused on finding out what works in Wales, we'd be much better placed to find good comparison groups. And that would allow us to do much more sophisticated experimental studies, which are nearly as good or even as good as an RCT. So we can do things like difference in difference, which is looking at trends over time, propensity matching, which is when you get a large group and you identify people who are particularly like the people who receive the intervention. Interrupted time series analysis, which is where something's introduced in lots of different places at lots of different points, when you can see what difference it makes. All of these work if you've got large data, or much larger data. So they don't work if you've got a little project working with 20 families or 50 families on its own. But if you've got a program of work that is pooling lots of such studies, you can begin to say really useful, interesting things. I think establishing outcomes is irreducibly complicated in children's social care, but I think it would be possible to work with the sector and with particular services to help them identify specific things that could be used. So for instance, distance traveled measures, specific instruments for specific types of services, certain things that could be used as practice tools, and then data used to begin to say things about the service. And I've got in mind the example of feedback informed treatment, which is a counselling approach, which said, essentially, it doesn't really matter what method you're using. What matters is constantly getting feedback about what difference you're making. So every session, the end, asking feedback with people about how useful it was, and similarly for supervisors to workers. And there's evidence that works. Could we build a feedback-informed system within children's social care? I think we probably could. I think we could also use technology much more. We could use local or national surveys of apps on the phone to get the views of children, young people, carers. We could also do polling and things. David Wilkins had the brilliant idea of using Ipsos Mori, and we published something last year. No, it was YouGov. But anyway, same principle, to find out what people think of the services they're receiving. And then the final thing in this bit is we could use data linkage. And I suppose this is a key strategic area for us to think about. So what we can do is anonymously get data about people's use of children's social care. So people who got allocated a worker, kids who came to care, whatever, people who were referred to an intensive family preservation service. And then we can link that data to their use of other services. So what health, how many of them were admitted to hospital in the next year or the next 5 years or whatever, crime, benefits, there's lots of data sets. And that would allow us to understand longer term outcomes data it allows us to get one of the holy grails of evaluation research, which is nearly 100% samples, very high samples. A problem in many studies, particularly in children's social care, is if you follow up families a year or 2 years later, you maybe only get 50% of families, what's happening with the other 50%. If you got agreement from them to find out anonymously how they used hospital services, etc., then you've got something that can be followed up long term, but also retrospectively, you can find out what patterns of use people had beforehand. So for instance, with children who go into secure accommodation, if we look back, how did they differ in their early use of services? You know, did they get visited by the health visitor differently? Who knows? But we could begin to unpick that. There's problems here with the time lag. For immediate use, it takes ages to actually do this. So we're talking about a year or two down the line, and for long-term outcomes, we get back into finding out stuff 4 or 5 years later. And we can only measure what the agencies measure. So if you want to measure families referred to intensive family support teams, you need to have that logged on your data set, and we're not there yet. But we have genuinely world-leading expertise with the CASCADE SAIL partnerships. So the SAIL database in Swansea, CASCADE's knowledge of children's social care. I doubt there's many places in the world who are better placed to develop this research. So I'm coming to an end, and there'll be time. I think someone's asked a question, which is great. I'm just going to go to the end, and then I'll take any questions people have. So the real problem, as I was saying, is that the research and practice are in these silos. I think we need to create evaluative research that is at the service of the sector, much more than at the service of people who fund research. And as a result, in order to achieve that, it needs to be funded in part by the sector or by government or someone to do this. I say it needs to be independent of external funding. It will need to be externally funded, but it needs to be separate from the process of applying for grants. There's a place for that, but that process doesn't allow us to do the sort of research that will give feedback into the system nearly quickly enough. And to do all that, it needs to prove it makes a difference. So I think we need a pre-funded and devoted program resource to do this work, carrying out quick, high-quality evaluations and pooling and sharing findings and giving feedback quickly to services so they can learn and use it quickly, as well as linking data for longer-term work for local authorities and the sector, so we can begin to look at longer-term patterns of use of services and outcomes, and exploring the potential of new technologies. This is an expensive thing to suggest. Completely made up figure I plonked on this slide yesterday without any thinking is it might cost £2 million a year to do it across Wales really well. It might cost much less if we picked a small number of local authorities and tried to do it with them first. But let's go big. Imagine a whole Wales service, £2 million per annum. That is a lot of money. But I think Scotland and England are investing far more in similar ventures. England's talking about tens of millions of pounds going into the What Works Centre. And also, that enormous amount is just the equivalent of keeping 2 children out of care in each local authority in 1 year. So £2 million, it sounds like a lot of money. It is a lot of money. But if it could actually genuinely improve outcomes, reduce the need for care, find the services that were working really well, share, and as a result, we began to get a real improvement in things like keeping kids out of care, then I think it begins to pay for itself. So for instance, coming back to the intensive family support teams, how much are we spending on them? How many of those are actually achieving their aim? And how much could we save by helping them be better, by identifying the ones that were really making a difference and the ones that were less so, to offering them a challenge to be as good as the best ones. So, final slide, and it's great to see some questions coming up already. I think we have fantastic opportunities in Wales. I think we've got genuinely world-leading research expertise, and we're a small country that has the potential to change quickly. We also have Cascade, where we could look. We've got some infrastructure funding. Maybe we could try to use some to develop this. Could we find partner local authorities? Could we get Welsh Government involved? Could we get research councils involved? Would the university support it? My guess is if you've got money from one place, a match from another, that's how you can begin to try to do something like this. But the key thing is to create a program where we're not applying for individual funding for individual projects, but we put together a program that is funded to do some of these things. So I tried to go through that very quickly because I wanted to leave time for questions and discussions. So I'm going to stop sharing, and I'm delighted that I can see some questions coming up. So Alison Rees says, I have a question.
Yeah, thank you, Donald. I think you were sort of inferring this, but my question is particularly thinking about the IFST teams, for example. So, you know, you found that they're good, so we set them up. What's our sort of longer term responsibility going forward to make sure that they are proving to be effective in the longer term, rather than just going off on their own individual journeys? And clearly that will be dependent on society changing, communities changing, COVID, all of those things. I'm just thinking what our long-term responsibility is to those. That was my question.
Yeah. I don't know, I can completely understand this. And I have to say, I can't answer all the questions people are going to ask. But my general point is, just because something worked once doesn't mean it will always work. Or just because it tends to work doesn't mean it always works. So we need to create a system that has feedback built into it. And I think we need researchers who are part of that, so that we can look at the different IFST teams and almost just offer them observations. We could be saying, you know, carefully, a lot of your kids still seem to go into care, or your kids don't seem to have as serious problems as ones in Newport, or whatever. Whereas I think at the moment we don't have that. And I think feedback loops are one of the things that are most strongly shown to drive improvement. And I just think we don't really have feedback loops, and we need to be thinking about that, I guess.
Yeah, and that's exactly what I was asking. Yeah, thank you.
Great, brilliant. John Franklin, and then John Callow. So let's start with John Franklin. Do you want to ask your question? Hi, John. I can see things happening. I think you're still on mute. Shall I go to, hello?
Right, sorry, my video is not working for some reason.
Great. Do you want to ask your question?
Yeah, sorry, I'm a practitioner, so I feel a little bit like, rather than a researcher, so I feel a little bit like I'm kind of sneaking in, listening to some experts. But my question is, I put a little note on the sidebar about moving from outcomes to process evaluations. I had a conversation with someone about this yesterday. I work in a local authority in a preventative role, so all our evidence is qualitative. It's very, very difficult when you're working with human beings to know whether what you're doing is making an impact. The context is really important. The narrative is really important. So I've got lots of questions really. One is I really appreciate what you said. I've learned a lot from it, but I don't see how we can do RCTs with human beings in one area, not offer people support in another area as a control group. Ethically, that's really difficult. Yeah. And we don't really know how, you know, when human beings' lives, we don't really know what other impacts they have. You could, you know, in your example about, you know, working with young people with families, there might be an influence, you know, that's coming from somewhere else, which makes a difference to them. So there's lots of that's a question, but also it's about how can we actually use people's stories, you know, qualitative, you know, their experience. How that seems to me that's really important, but it seems to be very criticised as being, of course they'll be very positive about it, but it seems that that's very powerful rather than just looking at data. Sorry, that's a bit of a ramble.
No. I'll try to respond to the various points you've raised. So about the ethics of RCTs, I agree that you can't always do an RCT, particularly in something like child protection or courts, etc. Ethically, there's two times we can do an RCT. One is when we're not sure whether something works or not. And I think the problem is we often just say, yeah, we know family group conferences work, but actually, do we? I mean, the evidence is, I think, that sometimes they work, sometimes they don't work. So I don't know if it would be unethical to say we'll give some families FGCs and others not. What seems to me unethical is offering them things when we don't know what difference they make. The second is a rationing thing, which is essentially when you've got more people needing a service than you can provide for, one of the ways of deciding who gets a service could be randomization. And if that helps you find out whether the service works, it can be worth doing. The second issue you mentioned about other influences is kind of why is part of the argument for randomized controlled trials. So much other stuff happens to families that it's very difficult to unpick the difference that a particular service makes. But where you can randomize and you have enough people, the events actually balance themselves out so that you know, the stuff that's happening in one group will be roughly equivalent to the stuff that's happening in the other group. Not if you have 5 families in each group, but if you have 50 or 100, then it sort of balances out. But you're absolutely right. That's why I said I think quasi-experimental studies are the thing that are more likely to be more useful. So I don't know what specific service you're working in, but the question is, are there other similar services across Wales, and could we look at a bunch of them so that you all began to understand and learn from one another better? The issue on stories, I am a bit skeptical about qualitative stories. Not totally skeptical, but I did a randomized controlled trial of training in motivational interviewing, and I provided the training and feedback, and the social workers were effusive with praise. They said it completely changed their practice. It was the most wonderful thing ever. But when I actually went and measured their practice, it hadn't made that big a difference. So yeah, self-report stories have a place, and I think you can try to capture some of that, but I suppose I am slightly skeptical of some of that, which I'd be happy to discuss further with you or others. But other people were asking questions. So John, now that was John Franklin. John Callow, an observation and a possible question.
Hi, yes, thank you for the talk. I have to declare my bias because I was a consultant social worker for IFSS, and now I manage the IFSS service in our area. I have to say, one of the crucial bits for its success was the consultation with social workers. And no matter what issues were going on in the family, you could predict the outcomes for that family depending on the consultation with the social worker in terms of their skills and confidence and threshold in terms of managing risk. And we still do it. Today, you know, we get a referral in and I can tell you what the outcome for that family is going to be probably before you even started working. And the short piece of work that we do of 4 to 6 weeks, I think just guarantees that the family and all the children are going to be safe. And it gives the confidence then to do some longer piece of work in terms of sort of addressing some of the issues. But it is, I think, from my observations, and this is coming from like 30 years of being a social worker, the process and system of children coming into care, once the management or those in charge of the case have made those decisions, then it's almost a sort of railroad track of sort of inevitability, and no matter what the family achieve, it will happen. And that is really difficult because, and I'm not quite sure how you would look at the research, and I've always been interested in the outcomes because I've been around long enough to see children that I've worked with survive their parents and grow up at home and in foster care. I wonder if we get too much caught up on actually what is a good outcome, because from my experience, most of the children in care have had pretty poor outcomes, and those that have scraped by in families where they may not have been the best of childhoods, but their outcomes don't seem that massively different. And it's where we sort of draw the line on what's important to us. Yes.
Though, as you said, that's an observation, not a question. Yeah. I agree with everything you've said, I think.
Yeah, but no, I'm just not sure what is the point of the research? Is it around better outcomes for children, or is it around better outcomes in terms of practice? Because I think it's down to almost how the practitioner works, the outcome.
Yeah, it's almost like I've got so many things to say I don't even know where to begin, because I think what you're pointing to is, and correct me if I'm wrong, that the individual social workers and their mindsets, values, and ways of working with families make a big difference. Is that?
They make an enormous difference, but I also think it's maybe not the social worker, it's the management structure in terms of how they report, because you can have social workers with a view, but if their line manager disagrees or their then service manager disagrees, that makes a huge difference in terms of what happens in terms of the end outcome, and also your legal process and how that's managed.
Yeah. So a problem we constantly have is of complexity, which is that it's a complicated system with a lot of moving parts, and they interact with each other in so many different ways that pulling out the things that matter is really, really difficult. And one of the things we need to do is try to create a more comprehensive ways of trying to understand some of those things. So for instance, am I allowed to say this? Well, let's just say generally in some research I'm doing at the moment, what we found is very big variations between local authorities in the values of the workers, and some indications that maybe their practices are different. So beginning to unpick some of that is absolutely crucial. It's crucial for fairness for families and children, so we can be sort of sure that they're getting something similar. But the most important reason is so that we can find out what really good people are doing and learn from them. And I don't even think we've begun to think about how to unpick that. I suppose what I'm thinking more is about, if you're working with a system and you want to do something new, how do we do new things in a way that allows us to quickly find out whether they're making a difference and then share our findings across the system. So I absolutely agree with your what you've said. And also, I mean, so much of it is difficult to capture. I got an email from, I mentioned this in more or less every talk I give because I was so happy about it. I got an email from a kid I worked with 25 years ago who said various nice things. It was really nice because I'd been worried what outcomes he had. You often don't discover them, do you? But he said one of the things he liked about me was, you know, the way I used to sing badly in the car to really rubbish pop music. And you think, well, you know, you can't really, social work is difficult to capture. It's a complicated thing, isn't it? It's not easy to scale it on a scale of 1 to 5. Anyway, so Jackie, do you want to say a bit more? Jackie Coogan?
Hi. Yeah, I was just commenting that, yeah, I completely agree with John. You know, I think a lot of it is down to individual social workers, their attitude to an assessment of risk and their confidence in kind of managing those risks. So it was just a comment really in agreement to what he was saying, but also he said at the beginning that children in Torvine were 5 times more likely to enter care than somewhere like Carmarthenshire. Is anybody kind of done a study around that, and do we understand what that's about? Whether, you know, surely the issues are the same or similar. I mean, I don't know the demographics of the area, but you know, what's that about? That's quite a high figure, isn't it?
Yeah. It's not just Carmarthenshire and Torvine. There's a lot of variation between local authorities. And for instance, while over the last 5 years, the number of kids in care has gone up 21% in Wales, you've got 2 or 3 local authorities where it's gone down. You've got several others where it's gone up even more. What is going on? I guess what this points, we're doing a bit of work which we've sent off to the Welsh Government, and once they've approved it, we'll publish it, which was a survey of practitioners, some of you may have done it, and leaders looking at differences between local authorities. I can't talk about the findings until it gets published, but I think they're really interesting. But I suppose related to the point you and John have made, both of you were saying it's the individual social worker. Yes, but if these variations exist at the local authority level, it's also the individual local authority. And I guess it is easier for us to begin to learn how local authorities vary than it is individual workers. And I think probably the focus of the sort of thing I'm talking about should be trying to learn from different local authorities who, whether they know it or not, are trying out new things all the time and sharing the things that seem to make a difference and things that don't. Individual worker variation is more difficult to get at, though I mean, it's also something I'm very interested in. But system or agency differences are something you can look at and understand better. But Jackie, fundamentally, and it's not just Wales, the same is true in England, why do we not know more about the differences that exist between local authorities when you can see very marked variations in practices? Yes, Helen has noted some briefings that she did, which are really useful, and I would really commend them to people. So she did a sort of quantitative analysis about variations. I don't know if you want to say a bit more, Helen, or whether you're happy to leave it at that. I don't want to put you on the spot.
No, it's fine. So there's three. I did an initial piece of work, which is quite a weighty tome. It's about over 100 pages, and it does try and explore, but some of the trends. It doesn't provide the answers, but it gives some sense of what's going on in the judiciary, what's going on in terms of population change, links to deprivation, the trigger trio. It is quite statistically orientated. And then what I did last year was update those. And there's 3 shorter briefings. And I think particularly where Donald has talked about kind of groupings of local authorities, there's one talking about flows in and out. And obviously, if you've got a system and you've got more people exiting than coming in, it's going to have the net effect is going to be a reduction. So I think that particular document is perhaps one of the most insightful and perhaps the more interesting ones to look at. But they, as I said, they don't give the answers about that kind of culture, practice, policy side of things and the difference, but it gives you a sense of where the differences do lie within Wales.
Brilliant. Thank you very much, Helen. Clive, you've made a couple of points. I don't know if you want to talk to them.
Yeah, well, I was just thinking Mark Drakeford's a social worker and used to be a professor of social work or social policy. So I wondered whether he might be up for, you know, trying to make up for the shortfall in money that compared to Scotland and England, that we can have those conversations.
Well, if you don't ask, you don't get, as someone once said. So I think it would be worth putting together something like this. I think the key thing may be trying to leverage it from different places so that each person feels that they're getting value for money. But I just sort of had this idea that we should be funded differently at the weekend. So it's early days to sort of think about how to progress it. But I think the key thing is this. So those of you who are from a practice background may not realize the really cumbersome way that we have to get research funding and that it takes years, it can often take a year or 2 to get funding. You're very likely not to get it. And then it takes quite a while to do the studies. And I just think we need something that allows us to work much more nimbly and quickly with local authorities so that if you are doing something in a different way, we can be working with you straight away to be clearer about what it is you're doing, to think about how you or we could collect data that might suggest it's making a difference, to give feedback quickly into the sector. Excellent. In fact, my gosh, we're at 12 o'clock already. I felt I could have waffled on about this endlessly, but thank you very much for all attending. We'll send around the slides. If you've got any questions or you want to take anything up with me, do drop me an email. My email's on the website and it's also on the slides. But thank you for asking such interesting questions and for attending. So thank you. I think that is what they used to call a wrap.